Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei podcast. It is my great pleasure to introduce our guest today, Dr. Artis Kalnins from the Riga Eastern University in Latvia. A great CTO operator, great fan. So Artis, thanks again for joining us today.
Good morning, Manos. Thank you very much for the invitation. It's an honor for me to participate in your podcast.
Artis, you have built a great program in Latvia doing CTOs for a while. How did you decide to build this program and when did that start?
I started my work in Riga East University Hospital in 1990 when I was a student. My first position was nurse assistant. And I started work in cardiology department, and when I finished my education in Latvian Medical Academy, it was clear that I want to be a cardiologist. And at first I started study in residency in internal medicine 3 years, and after that started study residency in cardiology with specialization in interventional cardiology. At this moment in 1990s in Latvia, we had only one hospital with interventional cardiology, and it's logistics that after residency I started to work in Paul Stradiņš hospital, where I can continue to work in interventional cardiology field. As a young operator, I was very enthusiastic and I was ready to do everything. And this time, 1990s, it was time where balloon angioplasty was very popular. We used a lot of mounted stents. Left main was taboo at that time because we had no drug-eluting stents. And bifurcation was for more experienced operators. But at that time, CTO PCIs was not very popular, and nobody wanted to treat CTOs. But I was very enthusiastic, and I was satisfied to start to do it, and I started to do. And results, of course, wasn't good, but it was really real life, and from the very beginning I had the interest about CTOs. 5 years I worked in Stradiņš Hospital, but in 2004 Riga East University Hospital invited me to start interventional cardiology program in Riga East Hospital. And I left Stradiņš Hospital and started to work as head of Department of Cardiology department, and parallel of that I started to do interventions. In 2004 I was alone in this hospital. I was responsible for all emergency cases, elective, planned cases. Together with me was only one young cardiologist who just started to do diagnostic procedures, and of course I did all kind of procedures, left mains, bifurcations, and also CTOs. And during the next 10 years I teached my staff. Now we are 6 cardiologists, but now I am the oldest, and traditionally I am doing all most complex cases till now. And since year 2000 I try to visit all biggest meetings in interventional cardiology in Europe and USA, and always I try to visit CTO sessions. And CTO is my main field of interest.
Wonderful. And for people who are not very familiar, so Latvia is a country on the northwest, and how's the population and how many cath labs are there?
Yeah, we are a small country. Our population is only 1.8 million, and in total we have now 4 cath labs. 4 cath labs, 2 is located in capital, in Riga, and third and fourth is second and third biggest cities. We are in total 25-30 interventionalists, and we know each other, and it helps in communication. It's much easier than in big countries. Yes, we are only 4 cath labs, but cath labs in capital are high volume cath labs. We performing 1,700 in our hospital PCIs every year, and of course many years we are working 24 hours.
Yeah, no, I cannot imagine, for 1.8 million to have 4 labs and 25-30 operators. That's you must be very, very busy. I'm sure for that. And that obviously helps with doing the complex intervention. Also helps with communication because, as you said, everyone knows probably everyone, and it's easier to communicate about those cases.
Yeah.
Now, when, as you said, when you were starting, these were the early days before the new equipment came through. Did you have people visit over? Did you visit other cath labs? How did you incorporate the newer CTO techniques into your practice?
When I started to do CTOs, it was really started to do it was in the year 2004. Abbott company was very active in this field because they was distributors of Asahi products, and they organized CTO workshops, small meetings in Scandinavia, and I visited. Etso Tsukikane was main guest operator, and I saw him walking, and it was very impressive and inspiring for me. And I saw him walking and tried to repeat these tips and tricks. Of course, at this time we didn't have good materials. First retrograde successful case I did in my cath lab in year 2007, and I did with choice floppy wire. I remember.
So those are the early good old days.
I remember this case very well. It was LID osteal occlusion with no stump, and I crossed the lesion retrograde from right artery with some resistance. Choice floppy went through this occlusion, and I use it as a marker wire. Yeah, and my learning basically was through self-study. I visited Toyohashi meeting in year 2008 and New York CTO meeting, and try to repeat these things here. And also I demonstrated my cases in local conferences, and some doctors from neighbor countries had interest about that, and in the year 2009 I started to organize our local CTO meetings. It was before Euro CTO Club. Initially it was only for Lithuania and Estonia, our neighbor countries. But now we continued these meetings next 15 years. Only during COVID time we skip meetings, and now we continue to learn. In first meetings I was main operator, but since year 2011 we have always have faculty. Masahisa Yamane is traditional our guest operator, and all presidents of Euro CTO club have been as a guest operators. Usually we collected very complex cases for these top 10 world operators. And no, it's very good for learning, yeah.
So it's great because you're able to see other people, also have them come over to the meeting. So clearly a lot of cross-pollination and communication with each other, which helps a lot. Now, when it comes to planning those cases, what is your usual routine?
No, I never do ad hoc procedures. And preparation, in my opinion, is very, very important. I try to prepare cases in advance. Always I analyze angiograms some days before, always one day before, and always at the day of procedure. And when I start my procedures, always my plan is clear. I always know which kind of materials I need, which guiding catheters I will use, which wires I will use, and which microcatheters, and plan is clear. And of course, sometimes plan doesn't work. For these cases, I have plan B always. I like to prepare a case. I am a little bit in trouble when I am going for proctoring. I am going to other country, other cath lab, because you never know what
equipment
they will have, and usually we see angiograms 30 minutes before the case, and I have no time to keep this case in my mind, and 30 minutes is a little bit the short time for me to make this plan. I don't worry about technical things, but I always worried in these workshops about plan is this will be right plan for opening or no.
Wonderful. And then how do you feel when you do those cases? Do you feel nervous? Do you feel anxious? Do you feel relaxed? How do you feel before doing these often complex procedures?
No, of course I was very nervous when I did the first retrograde case. I remember it very well. I remember very well first card technique case and first knuckle technique. I was very nervous, but now I am relaxed. I have seen all kinds of complications during 20 years in my cath lab, and I am ready. During these years, I collected different kind of materials and all equipment for complications. Yes, I can say that I am ready for everything now. Yeah.
Perfect. And are there any cases, you mentioned you remembered your first retrograde, are there any other cases that you learned a lot, good or bad ones, over the years?
Yes, I have some cases. I have in my practice some terrible cases and some very successful cases. I think my best case is a patient CTO case which I did with fourth attempt. This patient I met first time in 2004. He was admitted. I just started to work in Riga East Hospital, and this patient was admitted to my department with anterior wall STEMI and cardiogenic shock. We did emergency angiography and we found LID acute occlusion. which was open, and also patient had a very big right coronary artery with chronic total occlusion. In 2004, I tried to open this calcified right occlusion with antegrade approach, because at this moment I didn't have skills for retrograde, but procedure was not successful. I put this patient in my notebook, and when I started to do retrograde cases, I invited this patient once more and tried to open this CTO using retrograde approach. It was a year 2009, but lesion was so calcified and I couldn't penetrate this occlusion from retrograde side, not from antegrade side. When we started to organize CTO meetings and started to invite the best world operators, I once more found this case in my notebook and invited this patient for one of these workshops, and one guest operator tried to open this CTO case, but also without success. And in 2022, patient was admitted in my department with progressive heart failure. Ejection fraction was 25-30%, and at first we thought maybe patient have a new lesion. We did angiography, but patient still have a right coronary artery occlusion. And my first bare metal stent from 2004 was okay, and we decided to try to open this CTO fourth time. And fourth time, and this attempt was successful. I used base technique, knuckle antegrade. For retrograde approach, I use Carlino technique after knuckle retrograde, and it was possible to connect these two subintimal spaces. After that was used high pressure balloon, shockwave, two shockwave balloons for this severe calcification, and finally I did this case, this fourth attempt. And this case shows history of CTO PCI. I started with antegrade, then retrograde, and now the newest techniques and technologies, including shockwave, and finally I did this case. And
well, congratulations. I mean, that's a journey of 20 years, so that's amazing to see everything.
And also, yes, I remember one very terrible case, the most terrible case in my practice. This was 84 years old male after cabbage. It was 15 years after cabbage, all native arteries was occluded, and the patient had last remaining venous graft to LAD. And this last remaining venous graft also was treated several times with 3 layers of stents with restenosis. And patient was admitted with pulmonary edema in our department, and he had once more this restenosis in this last remaining vein graft, and I decided to help him and try to open occluded right artery through this last remaining venous graft, through LAD, through septals. It was in the year 2015 or 16, and I was very enthusiastic about successful results of retrograde approach, and I tried to cross this lesion with stiff wire and microcatheter support, but suddenly my retrograde wire together with microcatheter stuck inside this calcium through last remaining venous graft. It was third hour of procedure. I spent a lot of time, a lot of energy for removing, but I couldn't remove this stuck corsair, and wire inside. And after 6 hours, I send this patient to cardiac surgery. Yes, this patient was not good candidate for a redo operation because he was after cabbage and 84 years old and not in very good condition. And after this 6 hours procedure, patient was hemodynamically unstable. But finally, everything was good. Surgeons did his job. Patient was survived and he was discharged from the hospital. But I learned from this case a lot because surgeons found that my microcatheter was over-rotated. And it compressed inside a wire, and also surgeon couldn't remove this guiding catheter. And another significant finding was a big intramural hematoma, which sometimes happened in CTO, and this was main reason for instability, not microcatheter inside, but this huge hematoma, and I didn't see it in angiograms, but after this case I started to do much more careful patients after cabbage, and now I am not so aggressive operator than I was till this terrible case.
Yeah, no, thank you very much for sharing. And these are the cases that we all learn from, because we all had these very calcified cases, and bypass patients are often the ones with a lot of disease. And I would agree with you that usually you can get away with perforations, you can get away with dissections, but if you get things stuck, that's a much bigger problem, because if you can't remove it, then the patient often has to go to surgery, as happened in this case. But again, happy end, and as you said, lots of learning for all of us.
Yeah.
Now, Artis, you have, again, big cath lab, high volume. How do you teach people? What do you find the hardest thing to teach the fellows and the people who work with you?
As I said before, we are a small country, and we have 4 cath labs, and 3 of them are doing CTOs and retrograde cases. And we know very well from statistics that CTOs, we have only 10% of all lesions. And if you really want to be a good operator, you need to have a volume of procedures. And if we are doing 1,700 PCIs, that means that we have 150 to 200 CTOs procedures. In our cath lab we have a little bit less, it's approximately 125, and all my other doctors also wanted to do something. Usually I recommend for other doctors to start to calculate scores, GCTO score at least, and start to more simple cases. Don't try to open everything. When I start my work in the East Hospital, I was alone, and I did a lot of unsuccessful cases. I started with very complex cases. Today maybe it is not the best way how to learn. I think it's better try to assist for work together with more experienced doctor, at least some months, and then started to do simple cases. Till now I sometimes go for proctoring to neighbor countries, and also I recommended for young operators always calculate these scores and start with simple cases. And it's the best way, of course, if it is possible, to work together with experienced CTO operator. Yeah.
Perfect. Well, again, there's nothing, as you said, like a good teacher to help you get through. And when you learned, you had to learn on your own because there were not really that much proctoring as it is now. Techniques were still developing, whereas now techniques are much more mature. What excites you in an operator? Is there something you can see in a student or a fellow? Is it the technical skills, the attitude that makes you want to teach them and help them get better?
No, I think the most important thing is student or fellow interest. If somebody has interest about something, he will reach good results. If somebody don't have interest, it's impossible to become a good operator. I saw it in many places where I was as a proctor. If somebody really wants to do CTOs and have interest, he is doing everything to start to do, and he start to do. But if it is, by the way, one kind of procedures, I can go many years, many times, and they still inviting somebody. But people who really have interest and like this field, they always start and have a good result. And also, if we speak about result of procedure and success rate, I know very well from my experience that CTO PCI, it is teamwork. It's teamwork. It's not only one operator. Whole team is very important, and assistant is very important. And if you have assistant who is involved in this field, who have interest, you always have better results. But if you have an assistant who don't have any interest and who is waiting the end of procedure, it also makes me in trouble, and it's predictor of unsuccessful result. And usually in workshops and CTO meetings, results are much better than in real life, because this team spirit works, and all minds together. It helps to finish successfully case always.
Wonderful. And you're right, having the extra support from the panels and different ideas can make a big difference when you do complex cases like those. So, Artis, how do you deal with the challenges? Do you find them as an opportunity to do something different? Do you get frustrated when things don't go as you plan?
I always try to do the best in first attempt. But now during 20 years, I become much less aggressive than I was 15 years ago. When I started to do CTOs and retrograde, my main goal was to open artery and restore flow, and I was very satisfied about that. Now my plan is different. My plan is don't damage this case and finish this case without any kind of complications. My success rate decreases a little bit. It was more than 90%. Now it's 85%, because I am sure that in some cases it's better to stop procedure before some complications occur, before patient had some side branch occlusion or get myocardial infarction. It's better to stop procedure in investment stage procedure, maybe continue after 1-2 months. Because unsuccessful or successful case with complications, it's always not good long-time prognosis, and we must try to avoid complications as much as possible. Yeah, and
Perfect. And that's yeah.
sorry, and I said before that we organized these CTO meetings, and yes, I have cases when I don't understand what else I can do, and we collected these complex cases for more experienced operators for these CTO days, which we organize usually in April, and try to do together with more experienced operators. Yeah.
Wonderful. No, again, that's a wonderful approach, because you're right. In the beginning, it's a lot of focus on the lesion and getting the flow, as you said, and sometimes it's this global thinking that's come with experience that there is always a risk benefit, and trying to get the best solution for every problem. That's the way to go without taking too many risks as well. Artis, you have a high volume in the practice and doing many cases a year and a lot of responsibilities. How do you keep yourself in good shape and being able to perform at a high level?
It is not easy. I always recommend for my patients to do physical activities, but I spend many hours every working day in hospital, and in working days I don't have personally time for physical activities. But I am working also on duties in intensive care unit till now, and as an interventional cardiologist, but always I try to spend weekends in my weekends house, which is located 70 kilometers from Riga on the seaside, and this is time for me for relax and for physical activities. I like fishing. I have a boat, and I have license for fishing with nets in sea. Yes, and I am member of a local fishermen's community, and sometimes we together fishing together with local people. And also this location, seaside, it allows to do a lot of things. All our family, we have soup boards, and we have bikes, and sometimes in weekends we drive 30-40 kilometers with bikes, and I try to spend these weekends for my physical activities and for relax. Yeah.
Wonderful. So it looks like you work hard during the week and you recharge during the weekend.
Yeah. Yes. Yeah.
Wonderful. And then, how about any favorite book or any favorite movie, and why?
Unfortunately, for books, I don't have so much time, but I have want more education. When I finished school, when I was 80, 90 years old, it was very difficult for me to understand what I want to do, and I had two choices. One choice was medicine, and the other choice was to become a lawyer. And I have interest about legal issues till now. And when I studied in residency in cardiology, I also started to study in Latvian University, and I finished also Latvian University, and I have a degree of Bachelor of Law now, and I till now have interest about legal issues. It helps me in administrative work, and I like to read books about that, and try to follow these legal documents. Also, together with family, we like to watch movies. always we check American Academy Awards list and try to see all films which is included. Also this year, of course, I have my favorite film directors. It's Steven Spielberg and Lars von Trier, and I try to watch all movies. No, it's also we are doing in weekend evenings, together with family.
Wonderful. And then, what excites you the most right now in intervention? Is there something that you find exciting in terms of the techniques, the equipment, or the things that we're doing?
What exciting me, it's balloon angioplasties. I remember when I started my career in interventional cardiology, half of cases we did with balloon angioplasties, and after 10, 15 years, sometimes patients went back and the result was not so bad sometimes. And now this drug-coated balloons now is back, and in my practice I try sometimes to leave occlusions without stenting and full metal jacket. We know that this is bad thing, and maybe stenting is not necessary in every cases. No, of course we don't have trials about drug-coated balloons in CTO field, and maybe it's not for all cases, but no, I try more and more to shorten stenting segments, and more and more try to leave these occlusions without stenting, and the results really are not so bad. After 2-3 months, maybe you can put only short stent to fix most critical part, but I think it is a future of CTO treatment field. Try to avoid stenting. Yeah.
Wonderful. And then, what are your personal goals? What are you trying? What are you looking forward to in the next few years?
No, you mean in Latvia,
or for yourself, or I mean, career-wise, or what are your plans?
As I said before, we are a small country and a small community of operators, and we are very friendly for 3 hospitals who are doing CTOs. And this year we started a big plan. We started Latvia registry. It is impossible in big country with 100 of labs, but now we started to organize occlusion registry in the whole country, and we have first results after first 3 months. It's very interesting, and we definitely will publish this data, and this is our big project. To collect all CTO cases, to collect CTO PCI cases, and to know what we have today situation in one country. Yeah.
Well, congratulations. Again, it's hard to get things started. It takes a long time, a lot of preparation and planning, but it will be great results. So congratulations on starting this. Artis, what are you most proud of the things that you've done so far?
I'm proud about my clinics. Clinic I start alone, and now we have very good team, and we have 4 departments in our clinic. And in 2004 I was responsible for everything, but now I see that things happened and developing without me, and I have more time for me and for other things, and I'm really satisfied about that. Yeah.
Wonderful. And then, to conclude, if you have to give any advice to young operators or early career operators who want to become better and learn, what would your advice be?
No, my advice is try to visit as much as possible CTO meetings, workshops, try to go individually to other cat labs. When I started my career, I also visited Gerald Werner, Hans Butner in Germany personally for 2 days. I assisted him, and it was very good experience. And it is not so difficult to organize these short workshops. Also, some doctors are coming to my cat lab for 1 day to see me working. I personally try to plan only 1 or 2 cases per day, but for this special, for some guests, we can do a little bit more, and in other cat labs, I know situation is the same, and maybe it is better for young operators to go for 1-2 days to assist with these very experienced operators and to see in PCR meeting on the big screen one procedure. It's it's good, but better is if you can stand near the main operator and can ask him questions. I think this is very good for starting. Yeah.
Wonderful. Well, Artis, again, thank you so much for taking the time. Congratulations on building a phenomenal program in Latvia and all the surrounding countries, and looking forward to seeing the results from your registry.
Thank you.
Thank you for listening to the Sensei podcast.